First of all, you all are very fortunate. Never any batch had this integrated teaching program since the day this college started. And the credit goes first to Meda Madam, our respected principal and dean, the real star of this integrated teaching program, and a backbone for this program, who helped in coordinating between the departments, is Dr. Kirthi Koushik, who is in charge of the program. And this is a session where 3 departments have coordinated with each other. First is your favorite department, the anatomy department, then followed by pathology, then the ophthalmology department. So I welcome the staff of ophthalmology. Madam Mangala Gouri from pathology is going to come now and be with us. So first we'll start with the anatomy part using a model, and the models of the eye are placed in the behind this area. Then we'll start with the histopathological conditions, where they will show you the slides, histopathological slides of pathology and certain pathological conditions where you see changes in the eye, like it might be infection or it can be tumors. Ophthalmology department, they are going to present the dissection of the goat's eye, and they will show you the layers of the eyeball. Understand? And they will just demonstrate or speak upon the cataract surgery and a few words about the corneal transplant. So listen to that, the session or the guest lectures very carefully. I will hold a SAQ test for you all next week. Thank you. So I invite Dr. Prathap to talk upon the anatomical part of the eyeball. This model will show you the muscles as well as the layers of the eyeball, each layer by dismantling this model. Understand? He will also touch upon the development of a few words about the development.
Thank you, ma'am. This is the model of the orbit with the eyeball in place. Okay. What the brown color stuff over here is the muscles. Okay. So first we'll see this muscle over the eyeball. Okay. This muscle, which is over the eyeball. Can you see this? Levator palpebrae superioris. Okay. First muscle, levator palpebrae superioris. Okay. It elevates the upper eyelid. This one. Just underneath that, which is attached to the sclera of the eyeball from above, parallel to the eyeball. Superior rectus. Superior rectus. Okay. So I am going to remove that superior rectus. Okay. So you can make out this. This is the optic nerve. Optic nerve. Fine. So this on the lateral side, this is the right eyeball. So this is on the lateral side. So what rectus? This is lateral rectus. It causes abduction of the eyeball. So it's supplied by which nerve? Abducent nerve. That's why it's called abducent nerve. So this is the lateral rectus. Okay. So this is the optic nerve, superior rectus. So I'm just going to remove the optic nerve. You can see one more muscle over there. Okay. See? Can you see this rectus? On the inner side or the medial wall of the orbit. Okay, this is called medial rectus. Just above and parallel to this, can you make out this muscle? This is superior oblique. It's above and parallel to this, but for the eyeball it is obliquely coming backwards. That's why it's called superior oblique. So it passes through a pulley. It's called as trochlea. That's why the nerve supply for that is called trochlea. Medial rectus causes what action? Adduction. So after removing this optic now, can you see one muscle below the optic nerve? This one, brown color. What one finger is pointing? This one. It's an inferior rectus. Okay. This causes the eyeball to move downwards, and that is called depression. So all these extraocular muscles are supplied by oculomotor, third cranial nerve or the oculomotor, except superior cochlear nerve and lateral rectus supplied by. So can you make out a few fibers of inferior oblique? Can I tilt the model? Can you see this? This part. Got it? Our mom is putting the light over there. Okay. Got that? That is inferior oblique. Okay. So we now saw the extraocular muscles. Now I'll just dismantle the eyeball from its place and show you the layers of the eyeball. You can see this outermost covering of this eyeball. What is the outermost covering? This outermost covering of the eyeball is called the sclera, white in color. It's a connective tissue covering where the collagen fibers are running haphazardly. That's why it's white in color. When the same collagen fibers run parallel to one another, it becomes transparent like this. And that is cornea. The anterior 1/6 of the eyeball, it has got a cornea. So this is the sclera and this is a cornea, which is the outermost covering of the eyeball. It gives the shape to the eyeball, which is like a bulb. That's why the fascia is called as bulbar fascia. Okay. And it also maintains the intraocular tension and provides surface area for attachment of muscles. Okay. So this is the first layer of the eyeball. The second layer of the eyeball, where you are seeing the blood vessels, like red and blue color noodles. You are seeing now. This is choroid. What is this called? Choroid. The vascular layer of the eyeball is called as a choroid. So this choroid projects forwards. It forms one triangular shaped cylindrical body, circular body. This is this one. You are seeing the inner surface of the second layer, that is the choroid. Inner surface. On the anterior 1/6, it forms ciliary body, which in turn projects forward like a curtain. That's called as a iris or iris diaphragm. And that diaphragm has got an opening, pupil, to regulate the amount of light entering the eyeball. So this is a ciliary body, circularly placed. Okay. And in front of that one curtain is there, and that is the iris. In that opening is called as pupil. That will regulate the amount of light entering it. This is a biconvex lens. Can you make out? Biconvex lens, transparent structure. Biconvex lens. It is kept in this place by two capsule, anterior and posterior capsule, which is held onto the ciliary body by something called a suspensory ligament of lens. Suspensory ligament of lens. Okay, now I place that. So that suspensory ligament, you just have to imagine over here between this ciliary body and this transparent structure. That is suspensory ligament of lens. And this is a biconvex lens. It is disc shaped in 3 dimension, but in cut section it will be biconvex. Got it? This is the inferior oblique. Now you can see it more clearly. Look at the inferior oblique. This one coming from the floor of the orbit. This muscle, inferior oblique. Okay. Got it? This one. Okay. There is a jelly-like substance within this. Behind the lens. Behind the lens, there is one jelly-like substance. I am going to remove that. In reality, it's a jelly-like substance. It's called as vitreous humor. In this section, you'll see it better. This is called vitreous humor. Okay. In front of this lens, there is a watery liquid-like substance, and that is called as aqueous humor. So, in front of the lens, aqueous humor. Behind the lens, vitreous humor. Okay. When I remove those things, that is aqueous and vitreous humor, you can see the innermost layer of the eyeball. That is the nervous layer of the eyeball. It is called as a retina. It is available only in the posterior 5/6 of the eyeball. There is no anterior extension of this. This is the retina. Got it? Okay. Can you see? In the center of the optic now, can you make out some red and blue color dot? That's the central retinal artery and vein respectively. Artery and vein. You can see that central retinal artery and vein is coming out in the retina and splitting into 4 branches: superomedial, superolateral, inferomedial and infralateral. You can make out that? That is in the retina it's supplying. The yellow color stuff is the retina. That is the central retinal artery and vein. You see that artery is supplying the retina, vein is draining the retina. This on fundus examination or retinoscopy, you will see orange or yellowish hue across which you can see these blood vessels like this. Got it? This is the nervous layer of the eyeball or the innermost layer of the eyeball. Okay, that is about the model. So we'll come a little bit about the embryology. This is the model showing this is a diencephalon. Okay, or we can call it as forebrain. Initially we have a neural tube which has got cranial and caudal ends. Cranial end, caudal end or the lower end remains cylindrical, but the upper end dilates into three vesicles: forebrain, midbrain and hindbrain vesicle. The forebrain vesicle has got telencephalon, which forms the cerebral hemisphere, and diencephalon, which forms the future thalamus hypothalamus. This eyeball emerges as a eyeball development, emerges as a diverticulum from diencephalon. Initially it will be more lateral projection like this. Subsequently the maxillary process of either side pushes the eyeball towards the closer to the median plane or towards the midline. Initially the eyeball are directed laterally. This diverticulum from diencephalon is called as or termed as optic vesicle. What is it called? Optic vesicle. Initially it is a bulbar expansion. Okay. Later the mesoderm gets invaded and it converts it into a cup-like structure. It's called as optic cup. So what is it called? Optic cup. This optic vesicle, the proximal portion gets narrowed down to form a stalk. It's called as optic stalk. So this is the optic vesicle initially. Later it transforms itself into a cup-like structure, optic cup, and this one optic stalk. So this optic cup is the one which gives rise to retina, the nervous layer of the eyeball. Brain is now neuron only, na? So this is nervous layer of the eyeball. So there are two layers of the optic cup, inner layer and outer layer, which will contribute to give rise to 10 layers of the retina. So these are the two layers of the optic cup, inner layer of the optic cup, outer layer of the optic cup. Later the ganglion cell layer of the retina, the axons will invade the optic stalk and give rise to optic nerve. Since it is a diverticulum from diencephalon, it contains covering of the brain. What are the coverings of brain? Dura, arachnoid and pia mater. That's why in section of optic nerve you will see all these coverings being present. Got it? Okay, we can also see the surface ectoderm is getting thickened. Okay, it's called as lens placode. Lens, when this optic vesicle touches the surface ectoderm, here one thickening will form. That's called as lens placode. It will get detached like this in future and goes within the optic cup. This will form the future lens. So that's why the name is called lens placode, give rise to future lens. Okay, this one, biconvex structure. It's derived from lens placode that we can see in this model. In addition to that, this initially the lens is vascular. It will supplied by a blood vessel. It's called as hyaloid artery. Hyaloid artery. H-Y-A-L-O-I-D. Hyaloid artery. You can see that it's traversing in the center of the optic nerve. It is there in the vitreous humor. You can see that the vitreous humor and supplying the lens. You can see that. That's called as a hyaloid artery. Later, this hyaloid artery will be disappearing, but within the vitreous humor we can see one canal. That canal is for the hyaloid artery. But the proximal portion persists as the what artery? What artery do you think it is? Very good. So central retinal artery. It will persist over here. Distal portion should actually degenerate. What is yellow color layer? We'll see the model. Retina. Very good. Retina. Okay, this white color. Between that you have to imagine one narrow is there. There blue and red color you have to imagine. That is correct. This yellow color is retina. White color is sclera. Between that you have to imagine one choroid. Okay. What is the outermost covering of this eyeball? This grey color. Bulbar fissure. Correct. Very good. Bulbar fissure. This is the bulbar fissure. Got it? See, color code always you have to remember. This is the bulbar fissure. Understood? This is the anterior chamber, in which anterior and posterior chamber are two parts of the anterior segment of the eyeball, in which aqueous humor will be there. This is the posterior segment of the eyeball where jelly is there. That is vitreous humor. So this is the future lens. This is a future cornea. Got it? Cornea. This is a sclera. You can see that sclera is continuous with the sclera. Can you make out? Sclera is continuous with this, the cornea. Only the arrangement of collagen fiber and the vascularity differs. Got it? Okay, any doubts? You have got with this? Last, one more thing you can see here is conjunctiva. You can see this conjunctival pouch developing. This extra thing. I forgot. Conjunctival fornix. This one. So this will be what? This is conjunctiva. What is this? Eyelid. Very good. Eyelid. This is the eyelid. So this is conjunctival pouch. Got it? Any doubts? Okay, thank you, man, for providing this opportunity, and thanks for the patient listening.
Thank you, Prathap. Now I invite Dr. Mangala Gouri to touch upon the pathological aspects of the eye. She is a professor of pathology. She'll take care of you next year. Okay?
So I have to stand here. I can't stand outside because I have to manage it. Anyway, I'm audible now. So till now we saw the development. We have to remember one thing, that eye is one of a special gifts given to us. We can perceive the world only with eye. Afterwards, without that, they do excel in so many other things. That's an adaptation. But eye is very important for our, what to say, your learning of the world, your intellectual development, your speech, your interaction, your emotion, everything depends on eyes. And eyes can speak a lot. Even if you don't speak sometimes, eyes can speak. Agreed? Yes. So eyes are very important to us, and it's a God-given gift. I think we should save our eyes correctly and look after it well. At the same time, donation of eyes also is very important at aftermath of ours. And when it comes to eye, we see a lot of lesions. We actually go through a lot of pathological aspects of eye. So when it comes to that, there is plenty to speak, but I have restricted myself something too little. I want to create a curiosity amongst you all, so that you really understand what it is and you know what is going to happen with what subsequent changes. So with this, I want to start off. As I told you, good vision is very critical. So protect your eyes. Don't read everything on the entire portions towards the end of your term. Give little exercise so that you don't strain your eyes at the end. And my part role here is to deal with the inflammatory conditions, which is the commonest what we see. Apart from that, we have a few, just to create a sort of thinking or curiosity in you, I have put a few parasites which we can see in the eye, and of course tumors, which are a main part of our daily practice. Okay, so when it comes to inflammatory lesions, we should remember the conjunctivitis, what we call as the Madras eye or the red eye, whatever we want to say, that is the commonest. And conjunctivitis, it can be purulent, non-purulent, those are different stages. But ultimately, when it comes to inflammatory lesions, it is inflammation which can be acute and chronic. Acute means it comes for a day or two, you take a treatment, it just vanishes, you are back to normal. But if it lingers for more than 6 months, then we call it as chronic. Chronicity is something which we should not allow. So we as future clinicians, you should think that anything when it is seen at the first stage, you should try to remove the source and see if the patient comes back to normal. So as far as possible, making a diagnosis is not important. Trying to bring back the patient to as normal as possible should be our aim. Okay, so that is our main task, because we are getting educated in the field where we are going to treat the patients. Apart from that, we have the parasites. I have just put a few parasites there, and tumors are one of the mainstay, as I told you. So when it comes to parasites, I don't have much to show you on inflammatory lesions. It is just being treated, most of them, and biopsies really are not taken. I deal with biopsies. All biopsies taken from anywhere from the body, right from the head to the toe. For any lesion to be detected, it is my purview, and it is where we make a diagnosis, and we try to help out to make a diagnosis, or at least we throw surprises. Sometimes they think it is nothing and we say something. Sometimes they think it is malignancy and we say nothing. So there are surprises both for the clinicians and for us. So clinicians and we form a unit together to give a diagnosis. Okay, so when it comes to this, I will just talk about a few parasites. Ocular cysticercosis. Cysticercosis is something which we get as, what is it? It's a tapeworm. It can come from dogs, it can come from fish, it can come from pork. There are various, but cysticercosis cellulosa is what we generally see. It is from the pork, uncooked meat or partially cooked meat, and that it should be infected. cysticercosis. Recently we had a oral cavity lesion which was a nodular lesion. We thought it could be a submucous cyst, but when excised it turned out it showed this type of a worm inside, a cysticercus. Okay, and this is the covering. So this is a enucleated eyeball. Sometimes it can be seen, see the ova, they pass through the blood and they get lodged in any part of the body. Very rarely it does affect the eye, and this is one of the examples. You can see the cut section of the eyeball. What is this? Optic nerve. This is the corneal area, and this entire vitreous cavity is filled with pus-like material, and you can see the word sitting here. Can you see this? So that is the one, and ultimately histopathology is the gold standard. When it comes to histopathology, you have to identify what this is. According to me, this could be a conglomerate of a solid pus material. It could be necrotic tissue. So many things I can take as differential diagnosis when I see the gross. But microscopy is the one which actually throws light on what it is. So anytime I look into the gross, we always teach our postgraduates that when you see something, we have to come out with 2 to 3 differential diagnosis. Then we wait eagerly for the slides to find out whether we are on the right path. This is like an internal check to us. So as students, I am telling you, always an internal quality. When you are somewhere, suddenly sitting somewhere, you just think what you studied yesterday, can I remember? So those are the quality internal checks we do face according to each other. So this is the lesion from infected form. It can lodge in any organ. Commonly we see the skeletal muscle and subcutaneous tissue. Rarely it can extend into the central nervous system or the heart or eyes. And eyes is very rare, but there are opportunities or we can see them in our practice. So here the main features are, when it comes to clinical signs and symptoms, the patient can present with so many things, any of these, like proptosis, ptosis, pain, diplopia, double vision. Anything what he sees appears double, because something is pushing from behind. Okay, so those are some of them. And optical nerve involvement may not be there, but generally it forms a cyst-like structure, and for that when excised gives us the lesion. The next is very important aspects. All critically ill patients or patients with diabetes or patients who are immunosuppressive treatments can develop fungal infections. A lot of fungal infections are there prevailing. And mucormycosis is one of the ones. And this year I am talking about mucor because that is the one which commonly spreads from the nasal infection towards the brain. So you must remember that the nasal cavity, the orbit, the orbital socket and the brain are being separated by very thin plates of bone, and lot of blood vessels pass through it. And there is some amount of tissue passing through these areas. So infection can rapid, and mucormycosis is what starts. It easily enters when there is a spread, either if the patient is a diabetic or any other, having any other debilitating illness. So poor diabetic control is one of the important things, and the other is immunosuppression. Where do we get immunosuppression? Suppression is they are immunodeficient. Their immune system is excellent. You are suppressing it. Where do we get it? From the cases. Yes. So you have immunosuppression cases, and there is no surprise anytime they remove some tissue or from a given body, you find some new, either a parasite, sorry, not a parasite, either a fungus or any bacterial infection, which is commonly seen in that. So here what you should remember is they spread along the tissue planes, all along the blood vessels of the orbit, and when they block the blood vessels, they go within the blood vessels. When they block the blood vessels, what you find is thrombosis, and that area which is surrounding will not receive blood supply. Logic. So what happens? There will be necrosis and hemorrhagic necrosis, and then infarction. So infarction is the key word to say that yes, something could be going on and there is a block to the blood vessels. So here they spread by aerosols, spread into the lungs, and there is aggregation of these are the green one depicts the fungus. They are angioinvasive, they start invading the blood vessels. All neutrophils come into the picture and they tend to form microabscesses. So sometimes what happens, can you see this? This is the classical case of orbital mucormycosis with spreading infection or cellulitis type of picture seen in the surrounding skin. Okay. So here, how do we identify? See, there is something called as aspergillosis, there is something called as candida. In candida, there is something called as hyphae. So these are some of the things which we should be able to diagnose. So making a diagnosis is important. Here, what we find is large, non-septal, very irregular, ribbon or band-like hyphae with 90-degree angle branching. This is the feature to say that it is mucor. So here you are seeing the scleral tissue. This is the choroid. This is the scleral tissue. You can see that there is dense aggregates of neutrophils. So when you look into the microscope, you have something called as scanner view, a low par view and a high par view. So this is the scanner view. Then I move on to the high par. When I move on to the high par, I am seeing the same things, aggregates of neutrophils. Can you see these are all the lobes of the neutrophils? These are the neutrophil aggregates. But can you see that along the blood vessel something else is growing? Can you see this? And there is a branching at 90. And this is the longitudinal section. These are the cross section of these. Can you see that they are all very broad of irregular shapes and they have a angled 90-degree angle branching. This is a nerve bundle and it is invading into the nerve bundle also. Can you see them? These? Yes? From outside they are entering inside. So nerve bundle is being involved. And sometimes for us we get surprises. Something looks like this. But I am not able, can you see any fungus here now at this moment? So yes, no, I am not able to see. There is some amount of necrosis here and a small microabscess like thing. So I have a doubt in my mind. Could it be something else? Is there any etiology lying here? But these empty spaces sort of create curiosity to me. Okay? So I asked for a GMS stain, Gouri silver stain. When I ask for that, can you see that they are highlighted? Can you see this? Branching, they get highlighted. So this is where special stains play a role in aiding the pathology related to diagnosis. Where sometimes they look very pink and blue in a chili stain where we cannot make out anything. I am in doubt even if it's a single fungus I want to find out because treatment of the patient is important. Unless we treat the patient will never improve. So I got the diagnosis. Within 24 hours we get this done and we get a diagnosis. Can you see how well the GMS stain works? This is a silver impregnation test where only on the fungus the silver gets deposited. So it highlights even a single, see this, you got ribbon like irregular and this is a floating body. Any fungus, when it's exposed to atmospheric oxygen, it tends to produce a floating body. This is for dissemination or more growth or reproduction. So that is one. So for us it is a clue. If I know this lesion is having this, that means it is a cavity which is communicating to the atmosphere. If it is from the lung, I know there is a communication to the lung. So it gives a lot of, that's why knowledge is very important about how it is, where it is. And some small clues like this is enough to tell that this is a communicating thing and easily through the bronchoscope we can take a biopsy if required. The next I will tell you is on ocular filariasis. What is filariasis? Yes, they are small snake-like worms. They move just like snakes, but it is in the blood. But they can enter tissues. Once they enter tissues, which areas it is common? Coastal areas. And what spreads the infection? They mainly move through the lymphatics. Subcutaneous, ocular and serous cavity being involved is common in filariasis. The various species are plenty. You have Bancrofti, Brugia, Malai and Timori, but for eye we have a special type called as Lova. So when you see the adult because it's fully calcified. But you can always see the adult bone which is viable and it is removed. This is the slit slab examination showing you the live adult bone. Can you see this? In the sclera, you can see that the entire sclera is congested. And can you see it is sitting just beneath the sclera? Can you see this? Yes. So how do I see it under the microscope when it is sent to me? Cross section. Can you see the coelomic cavity? And these are the layers of the bilabial bone. This is a cross section. Sometimes you can get longitudinal section also, which I have not included here. And last but not the least, the most important diagnosis of retinoblastoma. With that, we have to enucleate the eye. Enucleation of the eye is the treatment for this. But very sad state that it is children who are commonly affected, between 2 to 8 years commonly. And you find that 60% are sporadic, whereas 40% are familial. If it is familial, it is autosomal dominant. So when you do a test, let's look into the eyes. When you find that the eye light reflects back, this is called as leukoporia, which is a diagnostic feature of retinoblastoma in clinical examination. And for this, you need to have a 2-level mutations to be occurring. And that is called as the Russell's 2-hit hypothesis, which is very, very important and crucial for retinoblastomas. How do they occur? Gross. Grossly, you find that they are small tumors which are creamy white with chronic areas of calcification. Yellowish necrotic areas can be seen. And when you really examine, it can be an exophytic growth, that is, it grows outwards from the eyeball, or it can grow inward. If it grows inwards into the eyeball, we call it as an endophytic tumor. If it grows extwards, it's called as exophytic. And it's generally a well-localized tumor within the eyeball. Rarely you find it infiltrating into the adjacent structures. So now this is the eyeball. What is this? What is this? Lens. This is the retina. Can you see here? Adjacent to the retina, you have a huge tumor growing like this. One more. Eyeball showing you the tumor.
Development, all is lost. It just becomes a gunny bag. Okay. Optic now concept. See this? This is where light that's the optic nerve. Okay, that's not optic nerve, that's the optic nerve opening. From there optic nerve will enter. So when we cut the optic nerve and cut all the muscle attachments and take out the whole eye, that is enucleation. Okay, so when do we do evisceration, where we take out everything and leave the sclera there? We do it in cases of, we call it as endophthalmitis, that is nothing but endo-ophthalmitis. Inflammation of structures within, okay, leaving the sclera. So why do we do that? If we do in case of inflammation within the eye, if we do enucleation, just now Prathap sir told you that optic nerve has layers of what? Fire, dura and all that. Now if you can make a cut there, what will happen? Infection will spread through that, go to the brain. We don't want that to happen. So endophthalmitis, you want to leave this protective covering around it. You want to only scoop out structures inside the infected structure, and we'll later suture it, and we'll probably put an implant also to give. Then we'll do a artificial eye and all those things. Okay, artificial eye only prosthesis. It does not have vision. Retina cannot be regenerated. Once the retina damage. Corneal transplantation, eye transplantation, whatever you hear, it's only cornea which gets transplanted, not the whole eye. Okay. So that was evisceration. If you cut what I took out first, right? That was enucleation. They were then enucleated and taken it out. Now we'll try to make one section and see. Dr. Mangala Gouri showed you cross section.
So light.
Lens popped out. I don't know if it comes because it depends upon the gel. Lens has come out, so I cannot show you that. Okay. Sorry, I bring the light here. This is the cornea, aqueous humor, which is, anterior chamber, which is collapsed. Iris, can you see it? No.
Light sir.
This is the cornea. This is the cornea. No.
Light sir.
This is the cornea. Iris behind. Aqueous, anterior chamber, aqueous humor. Then iris, the pupil. Then lens popped out, so we cannot show you. Then this is beautiful. I think you can all come in batches, and you can see these striations of ciliary process, lens nodules, and all that. Okay. Then vitreous gel, retina transparent behind it. Then you have the choroid, which also looks like iris only. Continuation of that. Then you have the sclera. Okay. So it's a small eye, but it is very important. 60% of your brain function is towards vision, right? So it's not actually small. So when we are doing cataract surgery, the lens popped out. We try to maintain the posterior capsule as it is. Okay, we'll only take out we'll make a small hole in the anterior capsule, take out the contents from within, and place the intraocular. Then we have a bag of capsule with the zonules attached. Then we put the artificial intraocular lens inside and close. Okay, we'll show you the videos now. Any questions? You can all come in batches, and then I'll again show it to you. Any questions?
What about other lens? It is two lenses are there.
It's got cut actually, because when I cut it, so they can come in this. Yeah. Oh. What you're seeing there is the lens. Pupil is dilated. Okay, we put some drops to dilate the pupil. And this is your lens, which has become opaque. Okay? Because of age,